a mobile phone. And his wrists must be absolutely aching at this point in terms of holding this up. So if we do take more breaks, it's because to give you time to kind of just get from your chairs and kind of move around. That's probably a public health kind of opportunity there, Louise, isn't it? Linking it across. But also, there are bits that we need to do, but we are running inevitably ahead of time. So, but I'm conscious that we do give Mark some breaks. You're doing a fantastic job, Mark.
Thank you, sir.
And I'm hoping your filters are. So, we're going to move on to demonstration of the People Story Dashboard. So, Andy and John, welcome to you. We are having technical differences today, but if you're going to turn your screens on, good to see you. I know what you look like. So, do you just want to introduce yourself? Oh, Jen, you're going to introduce first.
I would like to just say something before you start, if that's all right, Andrew.
That's right. Yeah. Hold you back.
I just want to give some context to the board before we dive in. So, this is the People Story Dashboard was one of our breakthrough programmes, which you'll remember, I think, when we worked through it. You'll have seen some of the, well, you regularly see in the performance report, some of the outputs from some of that dashboard. What you're about to see now, though, is quite unique and different. And so Andy and John, I can't thank you enough for the effort and the work that you've put into this. It is truly inspiring and is recognised nationally. So just so people are aware, the Department of Health were looking for case studies to be able to share nationally. And the People Story Dashboard has been chosen as one of those case studies. So I think really doubly important that we have a look at it today. So at that point I will hand over to you, Andy, but I just wanted to say a particular thank you to you and John.
And now you can introduce yourself.
Yes.
Thanks, Jen. Thanks, Jason. Yeah, hi everybody. My name's Andrew Barker. I am the Humber and North Yorkshire Strategic Workforce Planner. Over to you, John.
Cheers. Hey everyone, I'm John Holiday Robinson. I got married recently, so I need to be very conscious of my name to change. And I am a workforce analyst for Humber and North Yorkshire ICB.
Super. So it's going to be over to you. So you're going to do a presentation in empty for us, an opportunity for questions, and then I can kind of think about what we do next with this as well. So over to you two.
Thanks, Jason. So I'm just going to share my screen. Can everybody see that okay?
Yeah.
Excellent. So you were pleased to know there's only a couple of slides and then we're going to get right into the presentation really in the demo, because that's the crucial bit. So before we kind of get into it, I just wanted to discuss what the purpose was and the background really. So as Jane says, the People Story Dashboard really came about from one of the breakthrough committees. And the aim of it was really, really simple. It was to bring together as many elements of health and workforce into a really easy to use dashboard. So by doing that, we could start to think about population demand and what the workforce would be to support that. By having it all in one place, that really does kind of help to facilitate those planning conversations with our partners. So the dashboard itself actually includes a lot of data sets, as you can imagine. So first of all, it includes workforce. So we've sourced data from our NHS trusts, social care, primary care, KICS and PCSE. In terms of the demand, we pulled in some acute discharges, for example, so starting to look at the activity. The population, so again, thinking we're a demand harm, what's that census, deprivation data showing us, and then also the health risks as well. So once we kind of got the workforce in, we know what the demand is. What we then need to know is where is our future workforce coming from? So where's that supply? And for that, we started pulling some of that education data. So what's the attainment levels? What have we got in training? And what have we got that's actually economically active as well? And what I would say is, it's obviously evolving. So although that was the original purpose, and this is what we're looking at today, obviously the plans for this are kind of moving on, and what we will be doing is kind of changing some of that purpose to support some more committees and the new ways of working really throughout the reorganisation. What I would say is, the current functionality you're about to say will remain, so the planning element will always be in there. So what was our approach? So how have we done that? We know what the purpose is. So our approach is really all around collaboration and working collaboratively. And through the breakthrough committees, that's been a real key drive for us and to enable us to do that. So we've worked with healthcare colleagues, so NHS Trust Social Care, PCNs, KICS, PCSEs. We've worked with local authorities as well, so they've been a big player and a big part of this. Education providers, again, starting to think about that workforce supply element. And more recently, we've been working with the mayoral combined authorities to really start to develop the dashboard in supporting their work as well and get Brit working. Because it was developed in collaboration, one of the key things we had to do and address was make sure that it was accessible. So we had some technical issues we had to get around, which thankfully John's fixed. So what it is, it's accessible to everybody in HMY, all of our partners, and crucially, it's free. So it won't cost you anything to click that link. What we did do as well in the last version of the People Story, we had kind of a big bang approach for our comms as well. So we did a lot more work with our internal comms colleagues. So thank you very much for all the support that Tim did on that as well. It was really helpful. And through that, we've shaped what the People Story looks like. So we've received feedback from those comms, from people using it, and that's really helped to shape what the future's going to be. And then just to say that we view this as very much as being the beginning and not the end. So we know that myself and John are working on a new version, which I'm not going to give any timescales, don't worry, John, but we're hoping to have something out at the end of this year, beginning of next. So although, like I said, it is evolving and it will change, the actual crux of what you're going to see today will still be there. It'll just be enhanced. And then finally, really, the impact. So as always with these things, you can produce nice, pretty dashboards, but the question often is, so what? How are we using it? So this is just to highlight some of the examples that we know how it's being used across the system. So I know that our NHS provider colleagues are definitely using this for planning purposes. So they're using it to look at that demand, that population demand, and what that workforce is that's supplying. So they're using it for workforce planning, for example. We know as well that we're starting to shape it in terms of to support the Work Health and Skills Agenda, which is the Breakthrough Committee. Hull and East Yorkshire mayoral combined authorities are already using it, so they're already taking some of that data to support their Get Britain Working programme. I also know that it's been used to identify hotspots in local communities. For example, it's supporting the next chapter work that the HMY ICB are working on developing. And then finally, as Jane says, we know that it's been recognised by DHSE and it will be a national blueprint. So we're working on that at the moment to develop that national blueprint. And that national blueprint will be shared, obviously, nationally, and then as kind of an exemplar and best practice example. Right, over to you, John, now for the really good bit, the demo.
Cheers. Just one moment. There you go, it should be up now. So this is the People Story dashboard. So what I'll do is I'll quickly, because I'm conscious of time, I'll quickly run through the content of the dashboard, I'll explain the functionality of it, and I'll kind of give you some use case examples of the dashboard. So the first page is the population estimate page, reasonably self-explanatory, it's an estimate of the population. So we've got different hierarchies, you've got local authority, neighbourhood, which is an ICB grouping, electoral ward, all the way down to LSOA, which is roughly 1,000 to 3,000 people. So in terms of functionality, so if you're interested in a specific area, what you can do is, I'm biased because I live it all, click on Hull, it'll zoom in, then you can kind of see where the most densely populated areas of Hull are, for instance. So in terms of a use case of this page, we've got percentage of the population. So we've done work with the Frailty Network. So they'd be interested in patients who are of a certain age, so who's 75 plus. So then it's looking at, of all the people who live in that area, what is the proportion of those people who are 75 plus? And you can kind of see, got some neighbourhood work. You can kind of see predominantly East Riding, specifically Bridlands, and high proportion of people who are 75 plus. Population profile page. So this is pulling through predominantly census data, and we've also got deprivation data in there as well. So we've got disability, ethnic group information, self-reported general health, proficiency in English language, and the percentage of unpaid carers. This is just a first cut of it. There's other bits that we'll inevitably put in here as well. So for instance, if we look at self-reported bad or very bad health, there you go. It's quite a similar picture. So, yeah, again, looking predominantly at Bridlington, self-reported 9.23%. You can go down the hierarchy, you can look into this in more detail if you so wish. And then what you can also do is kind of cross-compare this with the deprivation data. Click on deprivation, and you kind of see how that kind of matches up, see if there's any correlation between those two things. Unsurprisingly, the more deprived the area is, the more likely it is that you're going to report that you've got bad or very good health. So yeah, that's population profile. Activity and health rates, this is quite a big page. Let me just reset that for a second. So this covers a multitude of things. So this first view is looking at acute discharges. Currently, we've got in heart attack data and stroke data. Again, this will inevitably expand when we engage with more networks. We're looking at different conditions, etc. But if we look at stroke, for instance, as we've done work with the stroke network, we do stroke discharges per 10,000 of the population. And you kind of see, based on where the patient lives, based on people who have been admitted to hospital with a stroke, where's the highest proportion of those people is standardized against 10,000 of the population. And there's also crude mortality data in there as well, see if there's any disproportionality in terms of the number of people who are dying due to a stroke following an admission. So that's acute discharges. We've also got health indicator data. Second, so this is coming from primary care. So this has got a lot of different things on it. It's got alcohol dependence, anxiety disorder, depression, frailty severity, smoking status, and weight status. The one thing I will mention in relation to this is the data coverage. So currently, there's roughly 36.5% of patients that we don't currently have data on. That is being actively worked on. So we're constantly getting more and more data through from primary care to support that. So again, looking at frailty severity, so we can have a look at percentage of people who have mild, moderate, or severe frailty. You kind of see where the highest proportion of those patients live. Again, kind of stick around with age profile and that sort of thing. And then finally, we've got physical activity, which is a reasonably new bit of data. So this is looking at people who are considered active or inactive. There's different definitions. What I should probably mention is that for all of the data sources, you can kind of hover over the map, see where it comes from. Where possible, there's a link to the data as well, so you can click that and then get access to that data as well. And there's also definitions of all the metrics if you're interested in how it's being calculated. So in this instance, physical activity levels, it's, if we look at inactivity, it's people who do 30 minutes or less of physical activity a week. And then again, kind of go by the map and kind of go through the hierarchy so you can do more targeted work. Labour market data. I'm conscious of time, so if you need me to hurry up, just tell me to, because otherwise I may potentially waffle on.
We'll let you know, but you're doing okay so far, John.
Oh, wonderful, thank you. So labour market information, so this is predominantly in relation to things like economic activity, qualification levels. It's all based off census data currently. So in terms of the work that we've been doing with the mayoral combined authorities, they're interested in people who are economically inactive, because that is part of the Get Great Working agenda. So you can have a look at percentage of people who are on long-term sick or economically inactive due to long-term sick or disability. And then what I'll come on to later is you can start having a look at that against things like the health indicator and the activity data to see if there's any kind of correlation in between people who are economically inactive and certain health conditions, anxiety, depression, etc., etc. Then we move on to the workforce aspect of it. So what you've got is full-time equivalent data, and you've also got headcount. For looking at local authority or neighbourhood, you want to be looking at it per 10,000 of the population, so that's standardised based on the size of the geography. So yeah, general practice data, probably better looking at neighbourhood for this one. So yeah, this is looking at all of the total workforce for general practice against 10,000 population. So if you're interested in, for instance, number of GPs per 10,000 of the population, you can kind of see that York has 7.9 GPs per 10,000 population, whereas Hull has 4.9. There's different staff group data in there as well, so there's more granular data, specifically if you're looking at direct patient care, you've got occupational therapists and all sorts of different bits. What we've also got is data showing where all the GP practices are, and then again, you can kind of hover over it and see the number of the full-time equivalents of the people who work there. And functionality-wise, it's exactly the same. So you can click on something like Hull, and you can see where all the GP practices are in Hull, for instance. Dental data works exactly the same way, so I won't dwell on it too much. Secondary care. So secondary care is covering the acute sector, it's covering mental health, and it's also covering the community interest companies. So what we have is, you can have a look at it by, this is all mapped to the HQ, but potentially more useful, although I will admit there are some data quality considerations in relation to the location, but where each individual member of staff is mapped in terms of their location of work. So what you can do is, because they all consistently use the same system, which is electronic staff record, each member of staff is assigned to an area of work. So again, if we go back to the example of the Frailty Network, you can have a look at people who work in elderly care medicine, and then we can also start adding in mental health aspects for older people. So then you're kind of looking at staff who are supporting Alzheimer's, dementia, etc. There's potentially some other bits and pieces, but it kind of gives you an idea. So this is a kind of initial cut of people who work with within like the frailty sector. What we've also got in here is occupation. So what you can do using this is, so for a staff group such as allied health professionals, for example, you can kind of get quite granular. You can have a look at occupational therapists, physiotherapists, etc. So that's kind of all in the occupation drop down. Social care. So social care works quite similarly. So this is looking at all of the care homes and hospices. It's currently only based on the independent sector. We're working with the local authorities to try and get hold of local authority social care data, but currently it's just based off the independent sector. VCSE, so this works slightly differently. So this is based off an internal survey that was taking place within the ICB. The data is at provider level. So as I said, it works slightly differently. So based on the data, you can see which providers work across North Yorkshire and all the different geographies, what the primary purpose of those providers are, target consumers, etc., etc. So just kind of give you an example. So looking at Frailty Network, for instance, if you're interested in providers who work with elderly or old people as part of their target consumer base, you can click that, filter all the data, you can have a look at the number of people who work with those providers, the services that they provide. BCSC. And then finally, so the last page, this brings it all together. So you can kind of do some, that's my fault because I took that age filter off, but at 70 plus. It brings all of the data together individuals so that you can start cross-comparing. And it holds the filters of the things that you've looked at on the previous pages. So currently we're looking at percentage of population for 75 plus, self-reported bad or very bad health, deprivation statistics, physical activity levels, and then what you can do is then see the workforce in relation to that. It's not tough it off, didn't I? So for instance, it could still be looking at the staff who work with frailty, for instance, and then you can kind of start doing some cross comparison, start looking for correlations between things, and again, it's kind of spot that planning work that Andy was talking about. So that's the dashboard in its current form. As Andy said, there's a lot of developments going on. It's forever evolving. If anyone has any questions, or if you're interested, want a more in-depth demo, feel free to get in touch with Andy and myself, and we'd be more than happy to do that.
Super. Thank you, John. Andy, anything else you want to say?
No, I think for me, you know, just to kind of highlight the fact that we are constantly evolving and changing it. So the more people who use it, the more feedback we get, and we really want for us to really kind of shape what people need. So the feedback that we get is absolutely crucial. It will change. I mean, I think the next iteration is quite exciting, isn't it, John? So we're going to have a headlines page with a summary that's going to almost start pulling out some opportunities down to a neighbourhood level. So we're quite excited by that. But that's going to be very much like an overlay, and then obviously we're going to dig into that. So I think just to kind of reiterate what John says, you know, if anybody wants to talk through it in a more detailed session, or if anybody wants to see how that could support their planning, give us a shout and we'll get something in the diary. Thank you.
So in the room, if we take Louise and then Teresa, or do you want to go first, Teresa?
No.
Louise, you go first, then Teresa.
You would expect me to say this, but anything that improves our understanding of the population is to be welcomed. I think the key thing is what we do and how intelligently we use what this tells us, and how that then links into joint strategic needs assessment, which is a statutory duty of us all, particularly local government and ICB, and how we use that from a strategic commissioner point of view. What I was keen to understand was how this links and works alongside tools like SHAPE that obviously the Department of Health and Social Care have endorsed, and that has quite a lot of intelligence and information that's similar in terms of mapping. But I am an absolute supporter of all of this. I'm only asking those questions about how we join up and use intelligently the data and information that these tools give us to really understand the need in the population, and therefore be able to commission services based upon need, and to have a rounded intelligence as we can on that basis.
Okay, so huge support there for the question around the alignment and the difference between this and other systems which are available. Andy.
Yeah, so it's a really good point, and it's something that myself and John have kind of been aware of really, and working alongside people such as Jake, for example. So we're aware of the developments that are happening internally and how that SHAPE is going to be used. For me, there is some crossover, but I think for us, we are using this for our like an internal development that is bespoke, if that makes sense. So for me, this is really around how we shift this to work health and skills. I think the most crucial part of this, though, is that we're all consistent and telling the same story. So the last thing we want, and this is why we're working very closely with Jake and the BI team, is to make sure that, you know, we don't say one thing and they've got something else. So it's all about making sure that those data sources are consistent.
Yeah. Okay. Teresa.
Yeah, so I just wanted to, I'm thinking through actually some of the utilisation of this as we go forward with things like neighbourhood health, for example, because this gives the opportunity to really drill down to actually understand the population within each of those neighbourhoods and understand the health needs within those neighbourhoods, and actually what services and professionals are actually already available and they've got access, the population's got access to. So really what the gaps are and what that particular neighbourhood health solution needs to focus on. And then I think it gives us the opportunity to actually demonstrate our commissioning in practice, if you like, so seeing the changes that we are making, both in terms of things like what health professionals are available to that population within that particular neighbourhood over time, for example. So I think it for me it's brilliant. It's shining a light. We've been able to do things sort of at a strategic and almost operational level, but this is really drilling down and giving us a true line of sight into the front line.
Jane.
I was just going to say thank you to both of you as well. You can't underestimate how much work has gone on over a period of time to get all of that workforce data. Even it's so impressive to see the voluntary sector information, John and Andy. I know how difficult that has been to try and to get your head around. And primary care, of course, quite challenging as well. So it's good to see the development. So you're right with what we say, that this continues to evolve and develop, but a lot of work goes into that.
Go Go on, we'll allow you. The spirit of partnership, Amanda.
Thank you. Yeah, I could do it in my existing role, couldn't I? John, can I ask, because one of the challenges that we've had, sorry, just to introduce myself, my name is Amanda Stanford. I'm currently this week Group Chief Nurse at Humber Health Partnership at the moment, but next week I'm coming into the ICB as a Chief Nurse. But one of the conversations that we've been driving is around digital capability. Have we got that data built into this as well, for having a look at where our communities are in terms of access to digital and digital literacy?
Not currently. That's definitely a good point. It's again, it's something that we could, so long as the data is available, add into it.
Yeah.
There are things that we've considered before. Like Andy and I have met with colleagues from local authorities. So things like access to like broadband accessibility, for instance, and that sort of thing. So yeah, no, that's a really good point. That's something that would be really useful to have in there. So it's something we'll look into.
Thank you. Yeah.
Merlin.
Yeah, it's just really absolutely great information. I may have missed it. I heard dementia, but I just wondered whether or not this is able to drill down in the world of children's, because we talked earlier about our statutory duty around JSNA. You know, in terms of the world I live in, is that our children have got significant complex needs, and they're getting more complex. And there are other things that will end up going into our adult services, like mental health, obesity, you know, all of those issues. And I just wonder whether or not we'll be able to see that data from a children's perspective.
Then, do you want me to pick that one up, John? Yeah, no, absolutely. So kind of in the demo, so we're just kind of focused on the work we're doing around frailty and stroke, because that was one of the networks. There is the child and mental health workforce in there as well, so we can drill into that. And that's some of the conversations that myself and John have been having. So we have got some anxiety and depression data in there as well, and mental health data in there. So that does allow us to flick on age and start to drill into that in some detail. What we're also working on is how do we pull in other elements of that child data, so for example, child poverty. So how do we start pulling all this data in to tell a story? It's certainly on kind of our list, isn't it, John, in terms of what we're pulling into the next version.
And that's really important, I think, Merlin, in terms of when we start to think about neighbourhood health being all age and the importance of the family health element of it. And I kind of think, as a starting point, this is great. What we do next with it and how that develops in partnership based on what people have and what people know that we need in terms of that future stuff. Very much, I think that evolution to People's Story Dashboard too, isn't it?
And what we can do to support them, because we know that there's gaps in getting that level of intelligence, so we're quite happy from a children's perspective to be part of those discussions if that would assist.
And this is very much a partnership tool. Nigel.
Yeah, what's in my head, and it might not make sense, but what's in my head is that we could use this as a modelling tool going forward, and a forecasting tool if we have the right amount of data. What we've got to be careful of, though, is not plugging gaps to make everywhere all right. We're more transformational than that. So actually, we've got to be careful that we just don't say, well, we need to shift that there to that there to get us all up to there. But actually, that's not very good either. You know what I mean? So what's in my head is we've got to be much more transformational about it. And so is there anything that we can use this as a modelling tool, look at either national, regional or worldwide exemplars on outcomes, to then start to map really what the workforce needs to look like, what we were talking about before with medical staffing. So rather than us just saying, well, we can normalise, utilise,
So,
if that makes sense.
Yeah, I think, I mean, obviously the guys will speak for themselves, but from my perspective, if I'm understanding what you're saying correctly, Nigel, I think that's not the tool thing, but actually the decisions that people are making on the basis of the information that the tool. And that's something about what's our ambition as an ICB, and what's therefore the decisions that we are making, which isn't actually just equalising everything to the just spreading everything out. It's actually where we actually invest to make the biggest gains for population health.
And potentially buy different things in different places based on what the data is going to say. So, I mean, I just kind of wanted to say, in terms of, I'm doing a lot of thought at the moment about legacy, ICB legacy, and the stuff that we take forward into the new world. And there's an awful lot to be proud of as an ICB, I think, in terms of the stuff that we've done over the past 4 years. And that change and that shift into a new world ICB isn't about not doing things well, it's about actually really firming up what our role is going to be. What strikes me is that we have a lot of things, a lot of assets that we have developed as an ICB that become so valuable in the new world, and this is one of them. And I'm immensely proud for this to come out of a board that I have chaired, where actually we always wanted to do the impossible, which was how can we get people to put data in one place, and how do we get people who don't have any data to do some data. So not underestimating the huge amount of work that Gary Sainty led on around the VCS workforce data. I said my previous job in the VCS, we have no workforce data. To see that in there, to see the start of some really, really strong, powerful stuff around social care, aligning social care with the NHS and saying, actually, if we go with a one workforce approach, we have a lot of assets, so we can't keep these things separately. Really, I think in a really good way, tackling some of the challenges around people collecting different things in different places and not telling everybody. And actually, that ability to look at this as the starting point and then say, what more could we do with this? Actually, how does this really drive what we do? You are on the right agenda today, because we've already had a conversation around workforce and the kind of some of our workforce mapping and our predictions for the future, and your people story dashboard really drives that. We're about to have a conversation around Get Britain Working and that huge alignment between stuff that we have. And I remember that conversation with Merrill Combined Authorities when they said, we have to do this plan. I don't suppose you've got any data. And the ability just to press a button and go, yeah, which bit of data do you want? I mean, that is a huge credit, I think, to you, Andy, John, the people who work with you on this, the People Story kind of dashboard team. It's called People Story, by the way, because I refuse to have a committee that's called data. So that's why it's called People Story. But I do think if we were looking back and saying the exemplar work, the stuff we're proud of in Humber and North Yorkshire, the stuff that we really need to celebrate at a time when things feel difficult and tricky, this is one of them. And I kind of think the national interest that has kind of come from this, everybody wants to come and talk about this, is a testament to the work you've done. It will never be finished, but actually thinking about where we are now, 4 years from where we were, in terms of what you've done, this actually is an amazing piece of work. So thank you. So, anything else you want to say to us? So you've now offered to meet with everybody around this table, because I can guarantee that I can see emails being written as we speak, Andy Barker, so careful what you wish for. And we'll see you in March. Anything else anybody wants to say in terms of that? And we can share the link, can't we? We had a big debate about who could access it. Yeah, everybody can access it now. I don't go on it because I'm sure I'm going to change the demographics of these writings. So, back up.
I'll send on the slides now, Jason, because the last one which I didn't show you has got the link.
It's got a link on it, hasn't it? Yeah, which is absolutely brilliant. And actually, the thing for me that kind of goes back into Nigel is we talk a lot about the importance of data, kind of in the new world. And data is great, but actually our commitment to do something with the data is the most important bit. So what do we do? What do we not do? What's the risk that we need to take? Actually, what's the outcome we really want based on the information? That's the bit that's going to drive us as a strategic commissioning organisation. But thank you for that. It's been lovely to see you both again.
Yeah, you too. Thanks for having us.
Super. See you soon. Bye-bye.
Bye.
So we have about 8 minutes for you to go and do stuff. Is your wrist really hurting now? 8 minutes to flex those wrists, Mr. Williams.
Easy now, really easy.
Yeah.
Got used to
Are
it.
you just kind of just getting body shocked?
But pulses, yeah.
8 minutes, and then at 5:30 we'll come back and we'll do the get ready working stuff.